Hello, ladies and gentlemen. Welcome to Cardiology Lectures. I am Dr. Nik Nikam. I have been a cardiologist at the Texas Medical Center for more than 3 decades. Today we are going to look at the role of digoxin in controlling ventricular rate in patients with atrial fibrillation. Should we or should we not use digoxin? This presentation was prompted by an important study that was reported at the American College of Cardiology meeting in 2017. So let's get into the presentation. Before I talk about the particular clinical observation that was highly quoted in the American College of Cardiology annual convention, I would like to start off with a case in point. There is a 74-year-old man in the intensive care unit with a history of severe COPD with acute exacerbation, RALS, active wheezing, coronary artery disease with severe congestive heart failure with a left ventricular ejection fraction of 36%, hypertension, diabetes, mild renal insufficiency with a creatinine of 1.3, a temperature of 102, respirations 26, pulse 149 per minute, irregular, and a blood pressure of 90 over 68 millimeters of mercury. The electrocardiogram shows atrial fibrillation with rapid ventricular response. The patient is already receiving antibiotics, losartan, Lasix, nitrates, metoprolol, 50 milligrams twice daily, insulin, and oxygen. You are consulted for control of ventricular rate in atrial fibrillation. Which drug would you use? Cardizem SR 180 milligrams daily, verapamil 80 milligrams every 8 hours daily, increase metoprolol to 100 milligrams twice daily, give digoxin 0.25 milligrams IV and repeat in 6 hours, followed by a dig level. Think about this for a moment. Let us discuss the merits of the article that was presented at the American College of Cardiology 2017. Then we will come back and visit this case and see what would be the most appropriate drug to use in this given clinical scenario. Before we go into the article, I want to look at the practice guidelines by the American College of Cardiology, American Heart Association, and the European Society of Cardiology. At the present time, the practice guidelines from the American College of Cardiology, American Heart Association, and the European Society of Cardiology recommend using digoxin for rate control in patients with atrial fibrillation. Point number 2. However, neither of them set guidelines on any specific recommendations about serum monitoring of digoxin. Is there a danger in using digoxin in such patients on a long-term basis? The Aristotle study looked at the adverse outcomes of using digoxin on a long-term basis in patients with atrial fibrillation with rapid ventricular response. Interestingly enough, the original Aristotle study was a randomized trial of apixaban, Eliquis versus warfarin for stroke prevention in atrial fibrillation. And these results were reported in the New England Journal of Medicine in 2011. In the same study, they also monitored 48 other patient-related parameters such as drug levels, adverse effects, among others. One interesting observation they looked at was the effect of digoxin on patient outcomes. They noted that 1/3 of the patients, that is 5,824, were receiving digoxin for control of ventricular rate in atrial fibrillation. All these patients had their digoxin levels measured. The outcomes were plotted. Based on the serum digoxin level. Now let's look at the results. Those patients who were not taking any digoxin whatsoever were used as the baseline, and obviously they had a DIG level of 0. Those patients who had a DIG level ranging from 0.9 to 1.2 nanogram per milliliter had a 16% increase in mortality over the baseline, but it was found to be statistically not significant. What was most startling was a dramatic increase in the mortality in patients whose DIG levels were greater than 1.2 nanograms per deciliter. There was a 56% increase in mortality among those patients who were taking digoxin and those who had DIG levels in excess of 1.2 nanograms per deciliter. Most of them died suddenly within the first 6 months. Another sad observation in this study was those patients who were started on digoxin during the study period had a considerably much higher overall all-cause mortality of 78% compared to those who were not taking digoxin whatsoever. So some of the observations that we can deduct from this fascinating study about using digoxin in patients with atrial fibrillation for control of ventricular rate include that there are still 30% of the patients who are receiving digoxin for rate control in atrial fibrillation. However, if we are to use digoxin in these patients, we have to use the digoxin very cautiously so we get the best results. Serum digoxin levels should be monitored very closely and frequently, preferably each month in the initial stages. The digoxin should be adjusted based on the serum digoxin level to keep the digoxin level below 0.9 nanograms per deciliter. In the initial stages, it may also even help to monitor these patients for proarrhythmias resulting from digitalis continuation or initiation. So we have learnt a great deal of new information from this study, and maybe with the new guidelines this information will be incorporated so that we become more knowledgeable physicians when we are using digoxin in patients with atrial fibrillation with rapid ventricular response. Keeping this information, the new knowledge in focus, now let us go back to our case and see should we or should we not use digoxin in this particular patient. Again, let's review the case. This is a 74-year-old man in the intensive care unit with a history of a severe COPD with acute exacerbation, RALS, acute wheezing, coronary artery disease with a severe congestive heart failure with a left ventricular ejection fraction of 36%, hypertension, diabetes, mild renal insufficiency with a creatinine of 1.3, temp of 102, respirations 26, pulse 149 per minute, irregular rhythm, and a blood pressure of 90 over 68 millimeters of mercury. What else can go wrong in this patient? The EKG, by the way, shows atrial fibrillation with rapid ventricular response. This patient is already receiving antibiotics, losartan, Lasix, nitrates, metoprolol 50 milligrams twice daily, insulin, and oxygen. You are consulted for control of ventricular rate in atrial fibrillation. What drug would you choose? Would you choose Cardizem SR 180 milligrams? Well, we can't use IV Cardizem because the patient's blood pressure is already 90/68, and further decrease in blood pressure could seriously compromise the cardiopulmonary status. For the same reason, we cannot use verapamil, even though verapamil may be a drug of choice in patients with chronic obstructive pulmonary disease, provided their vital signs are stable and provided they are able to tolerate the verapamil. But remember that this patient has congestive heart failure. His left ventricular ejection fraction is 36%, and combining verapamil along with metoprolol may not be the best choice. Can we increase the metoprolol to 100 milligrams twice daily? Even that may not be a very good choice in a patient who is already having very active wheezing and rales with a reduced ejection fraction and a low blood pressure. You may think like this is a cooked up case. Well, it is a cooked up case for this presentation, but the population I deal with on a daily basis, majority of the consults I get in the intensive care unit are patients with similar multi-system diseases, which makes it almost challenging to use any drug that is available to bring down the ventricular rate in an acute intensive care unit setup. So, what is the option that is left? Digoxin. What are some of the benefits of digoxin? From the previous studies, we know that digoxin can be useful in patients with acute decompensated heart failure. But in this study, they did not address the value of digoxin in patients with active heart failure. Anyway, keeping that aside, number two, digoxin does not decrease left ventricular function. In fact, it increases the left ventricular performance. Digoxin increases AV block, so you can reduce the ventricular rate, and digoxin does not drop the blood pressure like you would expect with a calcium channel blocker or a beta blocker. So, in conclusion, digoxin would be my choice, but keeping this Aristotle new observation in the back of my mind, I would be much more cautious in using digoxin to make sure that I use the minimum amount of digoxin that is needed to control the ventricular response rate, and then evaluate these patients at very frequent intervals to look for any proarrhythmia and perhaps maybe discontinue at a later stage if we can control their rate with conventional drugs like beta blockers. So this is my take on the role of digoxin in controlling rapid ventricular response in patients with atrial fibrillation, with the knowledge of the new observations that have been brought forth by the Aristotle study that was reported in the 2017 ACC convention. I am Dr. Nik Nikam, and thank you so much for watching, and we will see you next time.